Okay, now that we have the Zoom consideration sorted, let's talk about the key objectives and the agenda for today's webinar. CHWs have been at the forefront of our health system, acting as really vital links between communities and healthcare providers. So our first objective today would be to reflect on the evolving community health worker workforce, role of their community health workers in addressing health and equity challenges. Secondly, we hope to gain a comprehensive understanding of equity concerns from the onset of COVID-19 to the present day. Thirdly, we'll focus on articulating the state of the CHW movement and the need for infrastructure so that CHWs can adequately help address health and their social determinants. And lastly, we'll explore strategies for proactively addressing health inequities as a part of pandemic preparedness. So that's that's the ground we hope to cover today. And we have two excellent speakers who will be doing that for us. First, we'll have Dr. Sandra Galea, a renowned physician, epidemiologist, author, and the Dean of the Boston University School of Public Health joining us. Dr. Galea will discuss key points from his book, The Contagion Next Time, where he'll be talking about the importance of investing in public health measures, structures to prevent future crises, addressing health inequities proactively as a strategy for pandemic preparedness, and also how we can, and this is my favorite phrase, seize the opportunity to advance social and socioeconomic and political trends for healthier communities. Dr. Galea will be speaking for the first 30 minutes, and then we'll have our wonderful Denise Octavia Smith joining us. Denise is the inaugural executive director of the National Association of Community Health Workers and brings a wealth of experience to share with us today. Denise will lead us through a reflective and forward-looking discussion on the national context of the COVID-19 pandemic, current health inequities, inequities issues, and the evolving role of the CHW workforce. Denise will be speaking for the next 30 minutes of this webinar. Some of you may have already heard Denise speak at the Sustainability Summit, and for those of you who haven't, we have sent out a recording of her keynote speech in the reminder email, along with the book that Dr. Galea will be talking about during his speech. Once our speakers have concluded their presentations, we will have a Q&A session. So please use the Q&A function to post your questions. Our team members will be tracking them, and we'll try to get through as many of them as we can during the session. So I don't want to take any more time. And I would invite our speakers to start this dynamic session again. So Dr. Galea, the floor is all yours.
Thank you, Winnie, for hosting, for bringing us together. Thank you, everybody, for being here. It's really a privilege to be here with you. Particularly, it's a privilege to be sharing the stage, so to speak, with Denise Smith, whose work I very much respect and admire. And thank you for having me join for this session. So I was asked to talk a little bit about how I see what happened during COVID and to highlight what the challenges were that really resulted in the harms that COVID did, obviously with an eye to the future, with an eye to saying, how can we learn to do better in future? And as you heard from Winnie, a lot of this I wrote about in my book called The Contagion Next Time, which came out in 2021, which really tried to capture why I thought that what happened during COVID was largely driven by social, economic, cultural conditions, all of which we can tackle when we don't have a crisis in order to prevent such consequences in a future crisis. And in the context of community health workers and thinking about the role of community health workers in the context of a future disaster, a lot of this work, I think, has to be done by people at the community level working, though, to advocate for changing policies to create structures that create a healthier world long before a disaster hits. So that's the framework for my talk. Let me share my screen. All right, so I actually called the book that I'm talking about The Contagion Next Time, and the reason for that is many of you will recognize it's a homage to James Baldwin's The Fire Next Time, which is one of the most searing and I think important indictments about racism in America. The book is not about racism only, but it recognizes the importance of racism as one of many structural social factors that shape the world, that allows for the kind of calamity that emerged when a new coronavirus hit, as it did with COVID. Now, before I talk about that, I do want to start by pointing out that actually quite a bit went right during COVID. I know it sounds paradoxical to start this way, but I do think that I've telegraphed already what I'm going to say. But I don't want to forget that a lot did go right during COVID, and a lot of what went right reflects where we as a society have invested in. I will say explicitly that I'm taking a very US-centric focus in this talk. One could take a more global focus, but I'm here talking from a US-centric focus. And for example, things that went right where clinical care actually worked quite well in this country. This looks at a mortality rate, people admitted to hospital in the first days of COVID, March 2020, April 2020, May 2020. And all I want you to see is that we dropped mortality rate from a totally brand new disease that we had never heard of by fourfold within the course of 2 months. That is really quite extraordinary. We improved clinical experience. We improved use of pharmacological treatments, which is what we had at the time, better non-pharmacological treatment about how patients were positioned. And all of that happened in a rapid period of time. So our healthcare system really worked quite well once patients were in the system. And echoing what I said in my preamble, a lot of reason for that is because we spend a lot of money on our healthcare system, and a lot of money in our healthcare system actually means we have excellent healthcare system within its walls. As you can tell from my language, of course, the challenge is within its walls and who gets access to being inside those walls and how that then balances out with other things that we don't pay attention to. The other area in which we obviously did so well was in our vaccines. We had 2 vaccines that emerged within 8 months, which were 94-95% effective, which was extraordinary. It's hard to remember now, but in the spring and summer of 2020, there's a lot of conversation about what would we do with vaccines if they were 50% effective. Now, these vaccines built on decades of experience in vaccine development, but we never had vaccines that were developed in such a short period of time. The shortest ever we had was about 3 years. But they built on this novel platform, this mRNA technology platform that became, this from a paper that was published 10 years ago, that became a game-changing vaccine technology platform. But the point here to make is the point I was making earlier, which is that this emerged because we had invested substantially in vaccines and vaccine development ahead of this. So everything we're doing led up to us being quite successful in vaccine development, just like things we're doing before led up to us being quite successful in terms of health and healthcare. Now, having said that, of course, an enormous number of things went wrong. So much went wrong. This is from a headline in New York Times in May of 2020, which says US deaths near 100,000 and incalculable loss. Of course, at the end of the day, about 1.1 to 1.2 million people died from COVID in the US. So 100,000 was really just 1/10 of what the eventual death toll was. But this just reminds us of how stark, how shocking it was that this new disease came from nowhere and took so many lives. And this was from a map in the paper that showed really density of cases of COVID at the time. And the only reason I'm showing this map is because they chose red to the color. And I think you'll all share my feeling when you look at this map. You almost have a bit of a triggering bad memories. And you see, it feels like the whole country was on fire. In 2020, 2021, COVID became the 3rd leading cause of death in the US after heart disease and cancer. Now, speaking as I am in 2024, you're all thinking, yeah, we know that. But, if I were to tell you today, there's going to be a new disease that we've never heard of with a new name that we've never heard of at the beginning of 2025, that is going to become the 3rd leading cause of death, I think we'd all run for the hills. I think we would all say, oh my goodness, what can we possibly do to mitigate that? Because that is terrible. But it's exactly what happened. That's what happened. It resulted in a drop in life expectancy for women, for men, and it resulted in an unequal drop in life expectancy across people in different groups. And in particular, people from groups who are typically marginalized are suffered much more in the context of COVID than those who are not. Minoritized groups, as a shorthand, did much, much worse than did majority groups. This looks at the drop in the US life expectancy. The black line is everybody's drop in life expectancy. Everybody dropped life expectancy. But the purple line, if you just look at one line, is the drop in Indigenous American life expectancy, which dropped by about 6 years. 6-year drop in life expectancy is utterly unheard of. It is, just to put it in context, while we've had drops in life expectancy in the past 100 years, they've always been of the 0.1, 0.2, 0.3 range. 6 years is unheard of. It is higher than the drop in life expectancy was for young men who were sent off to war in World War II, just to give you a sense of how big a drop in life expectancy it was. And of course, this then brought to a fore these enormous social economic forces that we had long neglected as a country, to our deep shame. And that resulted in things like this, which is the largest civil uprisings that this country had ever seen, really ever in its histories, were larger than the civil uprisings that we had in 1968, 1969. As we had these tensions that were underlying, tensions around gender inequities, around racial inequities, economic inequities, all of which, because COVID showed how much these mattered, how much these became essentially embodied in our health. So with that preamble, then I say, okay, so why did it all go so wrong? So, the easy answer to that is you can say to me, well, it's because there was a new coronavirus, right? I get that. But the new coronavirus doesn't mean that it actually all had to go so wrong. What made it all go so wrong was the conditions, the underlying conditions that COVID found that were then ripe for a lot of things to go wrong. In the book, The Contagion Next Time, which I referred to at the beginning, is the opening line is, we were sitting ducks. And I say we're sitting ducks because all the conditions were in place for us to have terrible consequences when something like this were to happen. So I want to just summarize why things went wrong in just two simple notions. Notion A, we as a country had an unnecessary risk of acquiring COVID. Now, let me talk a little bit about that. The unnecessary risk of getting COVID largely was because of social patterning of underlying risk. The social patterning of risk that we, as a country, had allowed to happen. And there are many different ways of addressing this, but I will just point this out through one very, very simple way, which is by talking about something that happened in March of 2020, March 16th of 2020 to be precise, that largely none of us pushed back on. And that was the National Emergency Declaration that said the following, that said there's a new respiratory disease, and that respiratory disease transmitted person to person. So therefore, if you can work from home, you should work from home. That happened. And we all took it as sort of the right thing to do. Well, what happened once that emergency declaration came out? Well, here's what happened. The National Emergency Declaration is the yellow dot. And what you see is this is on the y-axis is the percent of people who actually stayed at home. The gray line are people in the top 20% wealthiest. The red line are people at the bottom 20% wealthiest. In fact, what you see is that the wealthier you were, the more likely you were to be able to stay at home. Why is that? Well, because the lower income you had, the less likely you were to be able to stay at home if you wanted to remain employed. We knew this long before COVID. These are data from the Bureau of Labor Statistics from 2019. These have nothing to do with COVID. Data from the Bureau of Labor Statistics in 2019 show that on the far right, among the people with the top 25% of income, a majority of those people can work from home if they want to. Everybody else, 75% of the working population, the majority of the working population, only a minority of the working population actually can work from home if they want to. That means that a national emergency declaration that says, if you can work from home, you should work from home, is akin to saying, we are going to pay attention to reducing the risk among people who make more money and exposing those who make less money to more risk. And that's exactly, of course, what happened. In the first year of COVID, the people who were likely to die were bus drivers, transit workers, warehouse workers. Those were the people who were likely to die. And those people are disproportionately people of color, people in historically minoritized populations in this country, particularly Black and African American. This looks at the people who are likely employed in essential industry, and you see that Black and American are much more likely employed in essential industry. There are people of all the other large racial ethnic groups in this country. So point A as to why it went so wrong is because we had a differential risk of getting COVID, and we expose people to the differential risk through policies that did not think through the risk that people really were going to be experiencing when we took those
One
policies.
that says allergy clinic or Dr. Mora?
I think somebody is
Yeah, you ring her, you ring hers.
all right.
Yeah.
I think somebody's on, if we can just mute, that probably would be good for everybody. Okay, let's move on to the unnecessary, to a second point. A second point is, so I'm talking about there's a necessary risk of getting COVID. There's also a necessary risk of getting severe COVID. Now, what do I mean by that? We knew right from the beginning of this pandemic that people with underlying health, poor health, were more likely to have severe COVID. This is data from 2020, February 2020, from the China CDC, that shows the death rate for people with underlying health conditions, heart disease, diabetes, chronic respiratory disease. Those people were much more likely, had a much higher risk of dying than those with no underlying risk. In fact, people with no underlying risk never had that high a chance of dying from COVID. Now, why does that matter? Well, underlying health risk is socially and economically patterned, deeply so in this country, as it is in many countries worldwide. This looks at household income decile from left to right. Left is poorer, right is richer. And what you see is the yellow is having underlying illness that makes you vulnerable to COVID. More income you have, less likely you are to have underlying illness makes you vulnerable to COVID. The green line, by the way, is having underlying mental health condition, which again makes you, by having underlying mental health condition, makes you more likely to have poor mental health in response to COVID. More income you have, less likely you are to have that. So having nothing at all to do with COVID, our differential risk for severe COVID was differentially distributed by resources. The more wealth you had, the less likely you were to have greater risk of severe COVID. And that, once again, was distributed unevenly by minoritized populations in different ways. This looks at Black populations, white populations. Black Americans are blue, white Americans are red. Different ages. On the left, you have high blood pressure, on the right, you have diabetes, two underlying conditions that matter enormously for complications from COVID. And which is Black Americans more likely to have high blood pressure and diabetes at young ages, middle ages, older ages, both high blood pressure and diabetes. And a lot of this underlying risk patterning that made us all vulnerable to COVID and made more people, some groups more vulnerable than others, goes back hundreds of years. It traces back some of the deep histories of injustice in this country, including the history of the enslavement of the African-American population. This is a map of enslaved Americans in the southern states in 1860. And this has had a long echo in this country, including echoing, for example, through patterns of things like redlining. This is redlining in the city of Chicago, which essentially was a project through the homeowners loan corporation in the country, where African Americans were denied loans to be able to buy homes as a result of not being able to accumulate generational wealth. And you see to this day patterns like this is the stroke belt in the US, where you see that these patterns mimic patterns of historical deprivation that go back to the history of slavery and other such injustices over time, all of which patterned the risk of underlying illness, which patterned the risk of underlying getting severe COVID. So then I come to, why did we get it so wrong? So given that these were the things that we got wrong, why did we get it so wrong? Now, there's many reasons why we got it wrong, but I would argue, again, that one can simplify this into two simple reasons. One is we underinvested in what makes us healthy, and two is we underinvested in what could have kept us healthy when COVID hit. Starting with the first one, underinvesting in what makes us healthy. Well, we know what makes us healthy. Everybody in this room knows what makes us healthy. Everybody in this room knows that doctors, medicines, antibiotics, drugs matter. But we also know that those matter only a little bit. What really matters to make us healthy is everything else in the world around us. Healthcare, based on this figure, based on this general understanding, this is a figure from the Institute of Clinical Systems Improvement, is 10-20% of our health. But what really matters is our smoking, our diet, our alcohol use, our sexual activity, where we live, our education, our job status, our family support, our income. How safe is our community? That's what really matters. And if we are underlying sick population with differential patterns of that illness that makes different groups differentially more vulnerable to the infliction of a new pandemic, that is because we have underinvested in what keeps us healthy. And that underinvestment is perhaps shown most dramatically when we look at what we spend our money on. The figure on the left is the same as the previous figure, just now it's just slightly different colors. And what I want to show you is I've put the medicine 20% in the neck and head of the figure. On the right is what we actually spend our money on. 90% of our money in health is spent on medicine, which really only accounts for about 10 to 20% of what causes health. Everything else we spend less than 10% on, despite the fact that it's 80 to 90% of everything else. So there is a mismatch. We have an unhealthy mismatch between what we spend our money on and what actually causes health. And that is underinvestment in what makes us healthy. We should make no mistake about it. We as a country spend an enormous amount of money on health. This is data, the most recent data, about 5 years old, looking at healthcare spending as a percent of GDP in this country over a 50-year period. The top line is the US. You see, we are spending much more than all the other lines. These are all colorful lines. They're all high-income countries. We spend 40% more than the next closest country on health expenditures, but all of that is going towards curative health, to the other parts of that infographic, not to the parts that actually create health. In fact, over time, we're actually doing worse on this. We have you see healthcare spending, which is the healthcare programs, which is the blue line, leaving aside Social Security. There's a whole lot of discussion. And you see spending on everything else getting less and less. This is why we were an unhealthy country long before COVID hit. Long before COVID hit, we as a country were 5 years behind in life expectancy compared to other high-income countries. And I often in my talks tell people that you in this country have chosen to live 5 years less than do people in other high-income countries. Sometimes when I say that, people get a little bit upset. They say, well, I didn't choose that. Which I say, well, you did, because we're choosing to be in a country which allows this kind of underinvestment to become poor health for all of us. And that is not the country we should be living in. We should be doing better than that. And we, of course, allow that to happen differentially. Again, differentially by wealth, differentially by education, differentially by assets, differentially by race. This looks at the mortality rate, black versus white. Again, same color scheme as before. Black is blue, white is red. And what you see is higher mortality for Black Americans and white Americans at young ages, middle ages, older ages. In fact, when you combine our life expectancy, which is on the y-axis here, and our spending on the x-axis, all the gray lines you see go together. Those are all other countries. The US, we're an outlier. We have more spending, but lower life expectancy, because we are underinvesting in the things that actually make us healthy, the things that matter to us at the community level, the things that are the subject of the work of community health workers. And the other point is we underinvested in what may have helped. If one would think about what may have helped during COVID, well, public health may have helped during COVID. And this was our state and local public health workforces over the 20 years before COVID, going down monotonously. We're systematically underinvesting in public health. Most states spend less than $100 per person on public health. These different hexagons represent the amount of money spent by states, which, sometimes when you present something like this, people may say, well, this money is only a finite amount of money, but our best estimates right now are that COVID cost the US $16 trillion. Now, it's actually hard for us as mere mortals to wrap our brain around $16 trillion, but just to ground it, $16 trillion is the same amount of money as is the GDP of China. That's our country's loss just because of COVID. So clearly, spending a little bit more than $100 per person might have been a better investment in public health. And in fact, bringing together some of the civil unrest that I talked about earlier, a lot of which was actually catalyzed by police killing of unarmed women, Black women and men. Most local governments spend more on policing than they do on health, which I think catalyzes in some respects some of the challenges that we have in them. So as I start winding down, because I have 3 more minutes and the time that was allotted to me, I'll talk about seizing COVID-19 moment of opportunity. I think there is a moment of opportunity here to seize, and I think those who work on the front lines, those who are engaged with community health work, have enormous opportunity to be leaders in that. And in some respects, not only is it a moment of opportunity, I actually think we don't have a choice, because there is a moment of public skepticism about the work that we do in science, in health. Public trust in science has gone down dramatically in the past several years. Went up at the beginning of COVID, and then it's been going down ever since. Trust in medicine has been going down. And in part, it's because people see that our health is not getting better. And they see all these efforts that have happened, and they see that we're not doing better. And it's hard for people to recognize that those of us who work within health, those of us who work within health, teaching health within communities, are constrained by these social constructs that create an unhealthy environment. I wrote this actually in a year before COVID, talking about we need a health new deal. And, every once in a while, you want to write something where you look back and you're like, yeah, I'm glad I wrote that. Now, of course, it didn't actually help any, but maybe now it's again that we actually need to rethink how we spend money on health in the US. I'll end with just 2 more slides. This was the cover of Time magazine in one of the covers of Time magazine in 2019, saying we're not ready for next pandemic. Those dangerous squiggly-looking lines in the back were Ebola, and I feel it's one of those covers that I used to say, well, yeah, we're not ready for next pandemic, and I think we're not ready for next pandemic today. We're not ready for next pandemic because we're not dealing with these underlying social economic forces that structure our risk for health differentially. We're not ready because we're not dealing with those underlying conditions. We're not ready because we have a population that is sicker and lives shorter lives than it should. We're not ready because we've been underinvesting in what keeps us healthy. And we're not ready because we've been underinvesting in what can actually protect our health. So this was the topic of my book, The Contagion Next Time, that Winnie kindly mentioned in the beginning. So the book came out in 2021. It captured these ideas. I often feel like sometimes one writes something and I feel like perhaps came out too early. I feel like the world almost wasn't ready to actually wrap its brain around this because, 2021, we're still sort of in the throes of acute COVID. But I'm hoping that the world is ready now. I'm hoping that the world is ready to actually wrap its brain around the conditions that shape our health so that we can actually act on it. Because the time to prevent the next pandemic is not when the next pandemic hits, but it's now. Thank you for having me. It's a privilege to be here.
Thank you so much, Dr. Galea. We have one question that I think would be really helpful if you address it right away. Someone in this has asked, can you please give us a definition of what you mean by differential pattern?
Yeah, what I meant was I was talking about differential pattern of risk. So what I meant by that is that if you have, let's say, underlying hypertension, or underlying high blood pressure, you have greater risk of severe COVID. And we know what patterns underlying hypertension, underlying high blood pressure, that is patterned by underlying assets, by whether or not you have education, whether or not you have wealth, whether or not you live in a walkable neighborhood. So there's differential patterns of social economic exposures that become differential patterns of risk factors that become differential patterns of risk that became differential patterns of COVID, severe COVID and COVID death.
Thank you. And thank you so much for the presentation. I think reading your book was such a delight, and like hearing you speak allowed us to zoom out and take a stock of where we were and need to be and understand
Wonderful.
what we need to do in the future. Thank you so much, Dr. Galea. Okay, that was a wonderful speech. And next up, we have Denise Octavia Smith. As I stated earlier, Denise will lead us through a reflective and forward-looking discussion of the national context of COVID-19 pandemic, the current health inequities, and the evolving role of the CHW workforce. Thank you so much for joining us, Denise. We're ready to go.
Oh, thank you. And I just want to, as I prepare my slides, just say thank you so much to Dr. Galea. I think I only wish that perhaps I could have met him a few years ago so that there could have been more opportunity for the co-learning, and I think in collaboration with community and with others, as we were all entering the pandemic and sort of learning in real time how we could best collaborate in a way that recognizes history and also positions us for equity and social justice. So I'll spend a couple of time today talking about CHW sustainability. I am really going to try to draw out some of the lessons learned around partnering with public health, but I will be certainly talking about the profession of community health workers and also strengthening our public health partnerships through policy. So first, there's always something to celebrate. And so the National Association of Community Health Workers is celebrating our 5-year anniversary. We have at least one of our founders, Darrell Fox, who is part of the JSI team. And so I just want to acknowledge and thank all of the founders and of course, all of our members for getting us to where we are. Members have made the difference for the National Association of Community Health Workers. It is the reason that we occupy a very prominent space as the national voice for a profession that speaks at minimum 28 different languages, moving across several hundreds of years of history, not only of the indigenous population, well over 700 tribes, 350 of them with CHR, Community Health Representative Programs, but also all of our diverse community from the Pacific Islander nations, descendants of enslaved Africans, those who have migrated here, who have found themselves as refugees or asylees. We have a very rich history, and so we have a lot to be proud of. And I just want to thank our members for trusting us and walking with us for these 5 years. If you're hearing about the National Association of Community Health Workers for the first time, I think a good grounding tool that I'll just reference quickly would be the new strategic plan that we have released. It really helps to talk about how we are evolving from an organization that was founded the year before the pandemic, and we largely grew up during the COVID-19 response. So it'll give you some insight of how we are shifting to sustainability as the national voice for CHWs, and also how we show up in the world, the ways in which we seek to amplify the unique identities and qualities of community health workers, how we are advancing and really disseminating the CHW research, workforce development, and sort of career pathways, innovations that we hope will be sustained into our future, how we're articulating our past, our present, our roles, etc. So we invite you to visit the website if you are interested in either becoming a member or understanding how you can partner with us for the strategic plan. So that I do not make any assumptions, I'm going to take 2 or 3 minutes and make sure that we are really on the same page. When I say community health worker, we've learned during COVID-19 that can mean very different things to different people. And so I'm going to leave you with 6 pillars that we developed in early 2021 after much learning about the global conversation of community health workers and what we felt was a significant sort of gap in understanding about our profession. Number 1, we are unique. We have our own U.S. Department of Labor classification. We were acknowledged and recognized as healthcare professionals in the Patient Protection and Affordable Care Act of 2010. Of course, we have the American Public Health Association definition of community health workers. And we have, as other professions have, developed our own set of competencies, skills, and qualities that define us. Number 2, we are community-based. And while COVID-19 brought recognition of our workforce, and no doubt you have seen us working in large health systems or in partnership with primary care in state or local health departments, federally qualified health centers, etc., we are best positioned as a workforce when we are able to sustain and enrich the established relationship and deep trust that we have with the communities where we come from and where we serve. Number 3, we are historic and diverse. And again, Dr. Galea gave recognition to much history in his talk. And I think I try to always make this incredibly personal. There's lots of data talking about the diversity of this profession. We have some of that data on our website. It's called the Data for Action series, and we invite you to check that out. But when people ask me, how far back does this profession go? I often ask people a question. How do you imagine that enslaved Africans survived for 250 years of chattel slavery without income, without access to education, without access to any formal healthcare system, without any rights or protections, and being in a foreign land? Who was birthing the babies? Who was addressing fever or snakebite? Who was addressing the mental health issues of families being ripped apart and sold, or physically, emotionally, mentally abused? These are the questions that help, I think, expand our thinking of who community health workers are. And when you begin to reach back into the history, you find rich traditions from all over the world, and I'm sure from diverse populations, as diverse as they may be on this call today. Number 4, we are a cross-sector workforce. For community health workers to address the whole health needs of individuals and families, many times we are stepping outside of the specific job description program that we might be employed in or volunteering in. When I was working in HIV, I often say for me to do the work of early intervention, pre-counseling and testing and connecting people to primary care, to build that relationship, that trust, and to support the journey of health and well-being. There were many other systems and supports that were needed for that individual and often for that family, dealing with income, a job opportunity, new career pathways, mental health, housing, food insecurity, clothing, health care coverage, etc. Number 5, we are a proven workforce. There are well over 6 decades of evidence of CHW effectiveness across a variety of chronic and infectious disease, maternal and child health, oral health, and a growing portfolio of evidence around the social determinants of health, which I might talk about a little later. And number 6, we are a precarious workforce. Around the world, and certainly here in these United States, community health workers are a predominantly female workforce, predominantly low income. We are the lowest paid of all public health professionals, and we do not have sustainable financing anywhere for the profession. There are over 24 states who do not recognize community health workers as a profession. And I think that all helps to undergird what we were experiencing as a profession and as the National Association of Community Health Workers during the first year in the early months of COVID-19. The very first thing that we wrote publicly was an article in Health Affairs talking about the need for community health workers, because if you can remember that far back to the spring of 2020, many CHWs were being furloughed. They were being laid off from their chronic disease roles, FQHCs, other positions, because people didn't necessarily understand how our roles, skills, and competencies, our qualities would translate to a global pandemic that many people thought was certainly clinical, certainly had a public health role and a need for intervention, but what was the role of community leaders, community organizations, community trust and expertise? We were very proud to partner early on in 2020 with US and global organizations like Partners in Health, Last Mile Health, and many US organizations like Health Leads or Health Begins, to center upon 3 really critical aims to center and integrate CHWs into COVID response. We saw the United States classify CHWs as essential critical infrastructure workers. That came from the US Department of Homeland Security, CISA. However, many states did not adopt that language, and so the CHW profession was not well integrated early on into COVID task forces, advisories, and responses. Number 2, we said that we needed to mobilize funding to scale the existing infrastructure of CHW networks, alliances, associations, because we knew they had capacity, experience, trust, relationship, innovation to engage diverse community members in contact tracing or care coordination. And then number 3, we wanted the CHW professionals, individual professionals across the country, to be recognized as leaders. And we often saw more of a sort of marginalizing of CHW voices until some other larger initiatives came online. One of the most significant of those initiatives was, of course, in early 2021 around the American Rescue Plan Act. So not discounting what happened in 2020, the prior administration released the first national initiative through the Office of Minority Health, the National COVID Resiliency Network that was coordinated by Morehouse School of Medicine. And we were a partner in those efforts beginning in the summer of 2020. But a significant ARPA act really helped to undergird and provide significant multi-year support. And this slide is far too complex for anyone to sort of read at a glance, but we know well over $7 billion went just to focus on COVID response, really prioritizing the work of community health workers, community-based organizations, our promotores de salud, and others. Well, along the way, as vaccines were coming online, as state health departments were receiving funding, as philanthropy was getting involved, as organizations were, scaling up COVID response, vaccine clinical trials, there were just a host of things happening, I'm sure, in your local area, your neck of the woods, and nationally. The National Association began to gain insight and to publish, to take interviews, to write about, to join coalitions, to highlight some of the structural barriers that community health workers and our CBO partners were experiencing. First, I just want to say there was an incredible level of stress for the community health worker profession. As Dr. Galea spoke about the disproportionate impact of COVID-19 infection, hospitalization, and death in communities of color, low-income communities, rural communities, tribal nations, many CHWs were on the front lines and experiencing just profound death, helping communities deal with isolation, the loss of jobs, inability to be with family as babies were being born, as elders were passing away. It was a difficult time. And so we shared some research about that. We helped to document when CHW said that they were not getting the infrastructure support they needed. And in fact, we partnered with a number of U.S. and global organizations and founded the Vaccine Equity Cooperative. And one of the things that we were talking about and providing recommendation for was the issue of addressing structural racism in how community-based organizations were receiving funding. We also talked about some of the inequities related to funding and partnership, specifically highlighting the work that we did to support this CNN article around NIH clinical trials and the fact that community-based organizations were not paid properly. We learned a lot during this time. And the National Association of Community Health Workers has well over 10% of our members who are from tribal nations. We tried to do what we could to also highlight what were the unique inequities experienced by hundreds of indigenous populations. And I think people may understand that pre-COVID, there had been historic and generational health disparities among tribal populations in terms of the prevalence of chronic disease, the disproportionate mortality from preventable disease. But during COVID-19, it became completely apparent that those treaties that established federal sovereign relationships were found wanting during COVID-19. We experienced through our CHR community health representative members the presence of a broken infrastructure. Difficult to have telehealth services expanded when you have no internet. Limited health services, disproportionate rates of immunocompromising diseases, as I mentioned, a lack of respect for tribe sovereignty and approaches to protect language keepers and elders. Many remember that when the vaccine came online, and if you can remember back to the 1A categories and the 1B categories, even the age range of vaccine access was not in alignment with the ages within the 40s or 50s that the tribal nations wanted, because those were many of their elders, and they needed to make sure that they could have an approach that would protect their elders and language keepers, and many other things that were experienced during that time. Well, fast forward to last spring and the signaling and the eventual unwinding of the public health emergency. We surveyed our members yet again, as we had done, to write all these articles and to sort of make all these statements over the course of those couple of years. And what we found once again from hundreds of our members is that COVID was still a reality. The impacts of COVID-19 were still happening in local communities, and CHWs were saying to the tune of well over 36% that they did not have the resources that they needed to respond to the impacts and the effects. Over 25%, 1 in 4, said that their employer was running out of funding and that CHWs may be losing their jobs. And of course, I was just at a large gathering in April in Washington State, where we heard that thousands of CHWs had been hired through CDC funding that went to state health departments for COVID-19 in the 2109 funding model. Now, those projects and those employed CHWs are on the clock. We saw as early as 2022, CHWs began losing funding for their roles, and today we're seeing that number really expand into the thousands as the 2109 is in its last year in many cases, even with a no-cost extension. We are doing our best to bring forward a view of what is the future. How can we take these lessons learned as we look to funding through the American Rescue Plan Act that is still in place? What is the now for communities, for community partnerships, for CHWs, and for public health? And so I want to just take a few minutes and say a recent commentary was released. I want to acknowledge the authors, including Alice T. Chen, who was leading the Made to Save initiative, Basola Ojikutu, who is leading the Boston Public Health Commission, John Arbach, a longtime public health leader who, just came out of some work with the CDC. We came together to write this article, and so I won't have too much time to unpack it here, but we surveyed community-based organizations and public health department leadership, and wanted to understand the key barriers and also bring forward some policy recommendations. And as your eye is sort of hovering over these now, I'll briefly say there is a risk to all of us that we might lose those innovations, those hard-won partnerships and relationships as funding for community-led programs begins to wane. Public health, more broadly, is still having a challenge of building its infrastructure. And I hope that we all recognize we cannot do it without community. I believe what Dr. Galea said. There is a next coming. And it is more important than ever that we do not continue to repeat the mistakes of the past, as we did, I believe, with the Affordable Care Act rollout, as we brought together many community organizations to get people to have healthcare coverage and to have a health insurance card. And then we dismantled largely that infrastructure. We did something similar during COVID-19. And so for us to not repeat those mistakes, it is important that we address the barriers of mistrust. In our CBO survey, only 18% of the CBOs said that they had high trust with their in their community partnerships with their local or state public health departments, while at the same time 100% of all of the public health leaders we surveyed said that trust was a high priority. There's a disconnect there. We have to address the separation of work and funding. And what we heard from those that we surveyed on both sides is that too often public health is seen as sort of the sole purveyor, right, of public health work rather than having an all of society funding approach and collaboration approach. So often funding becomes siloed, the work itself becomes siloed, and community does not feel that they are represented. And that was really the third key focus area we found in understanding what those barriers are. The recommendations are numerous, and I don't imagine that every health department has the resource or capacity or the readiness to do all 6 that are listed here. But as your eye is just coming over them, I think what I really am urging people is to consider how you can collapse those silos across your public health infrastructure. As Dr. Galea mentioned, so much of the high risk during COVID centered around those with in an immunocompromised state, those with underlying health conditions. Well, much of public health deals with those populations. And so how do we come together and collapse those silos and have a more strategic plan that acknowledges where those people are from a data perspective, from a geographic perspective, and ensure that community-based organizations and CHWs have the data, the infrastructure, the financial resource, the policy infrastructure to prioritize populations who are in need. And of course, there are other ways that you can center CHW voice through community councils by bolstering the CHW workforce. I'm sure my time is almost up. So really what I'm going to do here is just say, I'm going to share my slide deck with Winnie and the other members of the team. And I will just sort of highlight what we have, some of the things that were developed during COVID that I think are important to sustain this collaborative movement rooted in health equity. Number one, NACHWA has spent the last 18 months partnering with CDC to develop a definition of CHW sustainable financing and to offer a framework. And this actually has never been done before. And so I urge you to monitor the CDC website. We presented and released this, the high-level summary in April, but the full guidance, 45 pages or so, will be released by CDC. And I think this will be essential as you try to center CHWs and build sustainable infrastructure in your states. Number two, we have new CHW services, a cohort of them through Medicare, and we are working hard to work with Senator Bob Casey's office and many others to make sure that there is accessibility by eliminating a copay, but also just by making sure that primary care providers, health plans, health systems understand this opportunity in a way in which you can drive sustainability by expanding the physician fee schedule of 2024. We can strengthen, fund, and partner with CHW networks and state-level associations and community-based organizations. And NACHWA, we've partnered with the Association of State and Territorial Health Officials to provide a toolkit to make it easy for you to find these partners and for you to create equitable partnerships. Certainly during COVID, we had a global recognition of the need to address systemic or structural racism and violence as public health priorities. And the American Public Health Association released new guidance in terms of policy in late 2022, again, centering CHW's workforce as a workforce to advance equity and violence prevention. Of course, as I mentioned, through ARPA, we have an opportunity to deepen our equity commitments in workforce development, building our foundational capabilities, creating career pathways for more diverse individuals to come into public health, diverse in race, language, geography, and lived experience through the public health infrastructure funding that is now in every state health department. We should have a data-driven approach. How can we prioritize and target communities, populations, geographies who have structural barriers if we don't have good data? And so the National Association, we have provided a way for state health departments and others who are interested in developing a workforce study to understand the capacities of the CHW workforce in your geography. How do you do this work? We have those principles and strategies for you. Of course, we want to continue to press every single state to expand CHW's roles in Medicaid, to drive health equity, to drive prevention, to drive access to care, and to address access to our social needs. And so we have some resources there. And then finally, we invite each and every one of you to unite your voices with local, state level, or national community health workers to tell the story of success. We had a resolution that was passed in the House of Representatives through Congressman Ruiz's leadership, and we plan to do that again this year so that we continue to bring prominence to this workforce. How can you get involved? Well, as I mentioned, there are state associations and alliances that you can become a member of and support. You can also become a member of the National Association. You can register for a conference where a lot of CHW research, innovation, discussion is really incubated and disseminated, and you can participate in the second annual National CHW Awareness Week. And we'll throw some more information into the chat so that you can take part in that as well. Thank you so much for your time, and I look forward to the discussion.
Thank you so much, Denise. That was a brilliant presentation. I'm kind of sad I didn't get to see you in person now. But your reflections on this, the past, the present, and the future, I think ties it all together so well. And as we navigate forward, I think there's a lot that we can learn from what you've just said. So thank you so much. We'll now move on to the Q&A session. Participants, if you have any questions, please feel free to post them in the chat, and we will try our best to address them as many of them as we can. But in the meantime, I have a few questions for you, Denise. So should we get started? All right.
Sure.
Our first question was that you mentioned that CHW infrastructure keeps strengthening over time. As the CCR project comes to a close, do you feel it would be strong enough to address another public health emergency?
Wow, what a great question. So I think the first, something that I acknowledged just a minute ago is that we have not had a sort of common working definition of what is the infrastructure that is really needed to sustain the CHW workforce. And so I just want to acknowledge that our state and local county health departments, our tribal health departments, and many others in philanthropy, in government, in the private sector, we're sort of learning as we go to build this national infrastructure. Fast forward these number of years, I think many states and partnerships are wanting to tell the story of success and wanting to protect those successes. And so two things that I'll say. Number one, the infrastructure has to, it must look different in different geographies, in different localities, because of the capacities, the agreements, the consensus that exists on what those priorities are. CHWs are in every community, but they are not acknowledged or partnered with or recognized in the same way in every community. And so you have diversity of population, of language, of technology infrastructure, of partnership, of funding, et cetera. And then you also have this workforce that is already, sort of everywhere waiting to be a part of the conversation. I don't think that we are ready. If tomorrow we heard about another global pandemic, the question would be, how quickly could we bring community partners to the table? How quickly could we identify where community health workers are by zip code, and partner with them, and, you know, provide them with the information and training and resources that they would need to pay them for their work? So the short answer is no. I also want to acknowledge many thousands of public health workforce members left the workforce. So that we have a lot of work to do. And fortunately, the public health infrastructure resources should be there to help us prioritize and invest so that we are ready.
Thank you so much, Denise. We have a question from Michael, and he says, can you speak a little bit more about the dissemination guidance you would give to 2109 and their CHWs to share their stories?
Oh, yes. In other words, how can you share your story?
Yeah.
Yes, absolutely. And welcome back, Dr. Galea. You're here at the right time. Yeah, you know, as I mentioned, the National Association would invite your partnership. Later on today, we have a kickoff for the second annual National CHW Awareness Week. We brought just under 80 CHWs from around the country to the Capitol to share their stories. And so I think it's very important that public health, that primary care, that, you know, all public and private partners are, first of all, centering CHW voices and lived experience. Many CHWs were not prominent voices, although they were prominent actors. But for the 2109 teams, you've spent these last several years coming together and really wrestling with local structural barriers. And as I mentioned, sort of synthesizing and investing in your local innovations and assets. Those stories have to be told. Who are the priority populations that you were successfully able to engage? And how can the public health department and its partners and funders sustain those relationships, build deeper trust, and ready themselves for the future? So telling your story should always be in authentic partnership with CHWs. It should sort of think globally and act locally, understanding that a global pandemic is, as I mentioned, coming in the future. And so how will you prepare your infrastructure and your partnerships? And finally, I just want to say, the National Association, we try to do a lot to highlight those stories in our advocacy. And if there are ways that we can support 2109 grantees in getting those messages out. We did some of that in the health affairs commentary that I just mentioned that was released with myself and Alice Chen and others. And so we'll continue to highlight what those successes are.
Thank you so much, Denise. Denise, we have one more question for you, but we also have a question for Dr. Galea in the meantime. So I'm just going to go to him first, and then we'll come back to you. Dr. Galea, there's a question saying, you forecast future public health emergencies. What role would you say CHWs might play in ensuring adequate public health infrastructure to meet those threats?
Yeah, thank you. First of all, apologies. I had to step outside for 5 minutes. I had to deal with something. Secondly, one of the challenges with forecasting that happened during the pandemic, during the acute phase of the pandemic, was that the forecasting was removed from realities on the ground, and the forecasting was happening in a sort of in a vacuum, to think of it from a scientific point of view. And of course, that's not where the real world happens. So I actually think having community engagement and inputs, real world inputs, to talk statistical speak for a second, this is called, priors, and the priors have to come from real world experience. So I actually think that one of the many, many things that we should have learned during COVID is that you need community engagement in the asking research questions, and prediction is a research question, in the proper context to make a difference.
Thank you so much. Okay, one more question for Denise. Can you offer any examples that you may be aware of regarding the impact of the CCR on these opportunities and challenges that we've been discussing during our session today?
Well, certainly the 2109, 2110 innovation was the first of its kind for community health workers to have prominent and multi-year funding, right? To be recognized as a part of the public health infrastructure from the federal government through the states and into localities. We saw many incredible partnerships. I think of Papakolea, some of our partners in Hawaii. I'm thinking about the Florida CHW coalition. I mean, I can think about many opportunities where promotoras, where aunties from the Marshallese and Hawaiian community, communities all over had an opportunity for the first time to be recognized as leaders, to be recognized as part of the public health infrastructure in terms of employment and planning, strategic planning. I also want to celebrate that CCR, allowed opportunities to discuss sustainability. And doing that in at the same time that people were responding to a pandemic was completely novel, right? States have not had significant funding or time to come together with community partners, or investment to come together with community partners and talk about sustainability, to survey what is the infrastructure, the capacity from a policy perspective, a data, a workforce development perspective, right, to drive sustainability for CHWs. And this is something that state health departments have been struggling with for many, many decades. As I mentioned, I worked in chronic disease in my state of Connecticut. I worked in HIV/AIDS, and always that funding was short-term. Always the partnerships, dissipated and had to wait until the next round of funding. But the lesson here through COVID is that many of the same communities living with diabetes, are many of the same communities living with obesity, are many of the same communities who are low income, are many of the same communities who are on Medicaid. So we have so many layers of risk that coming together in the 2109 helped to prioritize some of those communities through the CHW innovation. So I am hoping that that work and those conversations continue. And as I mentioned, I think the definition of sustainable financing that CDC is releasing and the framework will help people identify what were you able to build during these last couple of years, and what is left to do, and how can you prioritize those aspects of the framework to build that sustainable financing.
Okay, thank you, Denise. And I think our next question is right in line with what you just said. And this is for both Dr. Galea and you. And the question is from Terry. Like, despite the challenges ahead, do you feel optimistic that public health will strengthen alongside an integrated CHW workforce?
Denise, you want to go first?
Yeah, my short answer is yes. As I mentioned in my talk, we have had incredible support. Public health has held up and incubated the CHW profession. Many people may know that the National Association of Community Health Workers, that its founders came out of a special interest group from APHA. Right, we've always been closely tied together. There's always been a recognition from our public health partners of the value of CHWs formally and informally. So I think that there's no sort of going back. I think the challenge is, how do we retain the knowledge, right, the infrastructure, the champions within public health departments to ensure right? That CHWs, our associations, our alliances are at the table for state health innovation planning and for planning around emergency response in chronic disease. How do we recognize that CHWs, diverse in language, geography, race, ethnicity, lived experience, should have pathways into public health? Right? That is more the difficult work. And I think the American Rescue Plan funding in the public health infrastructure model that is now in all of the 50 state health departments and in all the territories and island states, now we have to leverage that funding for planning, right? That's the work that needs to be done. So I don't think it's for lack of will or for lack of recognition. I think it's about planning and prioritizing.
Yeah, and if I may add to that, I agree completely with Denise, which I thought I would. Well, I am optimistic dispositionally because I think it's better than the alternative. But secondly, I actually am optimistic because I think COVID, one of the tragedies of COVID was that it surfaced these deeply seated issues that, those of us who have been in the field have known for decades. There's nothing new about what happened in COVID, but all of a sudden it made them publicly recognized or put them on the front page. And I think that has motivated a public conversation. I was just today, Denise made reference to a report with which the Boston Health Commissioner, Dr. Bisola Ojikutu, was a co-author on, and I was just at the event a couple of hours ago with her and the mayor of Boston, launching a health equity effort in Boston. And, the language of the mayor was sort of entirely out of what I think one might call a foundational approach to public health playbook. And it is fabulous to see that. I think more and more elected officials are understanding these issues. Now, I think for those of us who are in the field, sometimes, one despairs. It's reasonable to say, it's taking so long, it's never going to happen. But that's how the world changes. The world changes slowly. So yes, I am optimistic. Optimism is not in contradiction with saying that there's much work that needs to be done. Hans Rosling, who was a scholar in Sweden, used to say that the world is a terrible place. The world needs to be much better, but the world's much better than it's ever been. And I tend to subscribe to that.
I think I read that in one of your books as well. And
Yes,
it made me really happy.
I really like that. I think all these
Yes.
things are true. I think sometimes we have a hard time, we're human. We have a hard time holding contradictions in our head. How is it possible the world's a terrible place, but the world's a better place than it's ever been? But it is possible. It is true. That's not meant to say, it's all okay, don't worry about it. No, it's meant to, there's a lot of things that we can do and we should work hard to do better. But it's also okay to say that we are doing better on a number of things.
Thank you so much for I think that is a very good note to end our webinar series on today. So thank you so much to Denise and Dr. Galea for our session. And I muted myself. Participants, please hold on. We do need help with something in the last 15 minutes of the webinar. But thank you, Dr. Galea. Thank you, Dr. Denise Smith, for joining us today.
Thank you for having us.
Yes.
Bye-bye.
Bye. Okay. And it has been an absolute pleasure and the privilege to work with the 2109 CHWs and special guests to offer the series of CCR webinars. Our future training offerings will be in support of your ability to broadly disseminate what your programs have accomplished. This may be in the format other than a webinar. So as the official CCR timeline has come to a close, can you please answer the following brief poll so that we can learn about what might be the most helpful to you? Cynthia, if you can launch the poll. And people who are joining us today, we would really appreciate if you can take the time to fill out the poll for us. We are going to leave this poll up. We really appreciate your input, and it will help us guide our work in the coming year. Thank you all very much for the participation today. We are grateful that we could share the space with us, and we look forward to meeting you soon. We will share the recording of this webinar on AMP in the coming days, so please feel free to revisit it and share with the others. Please take your time to complete the poll. And once again, thank you for joining us today.